For some reason, I'm having a recording issue. Hold on. So, Whitney, just hit the record. Elizabeth, take it away.
Thank you, Maria. Welcome, everyone, to today's cyber seminar. My name is Elizabeth Patton. I'm an obstetrician gynecologist and consultant to the Office of Women's Health at the VA. And along with my co-moderator, Jodie Katon, we're really glad to welcome you here today and be here to moderate this session. I want to take a few minutes to just briefly introduce the panelists as well as Dr. Katon, and then we'll proceed with the seminar. So Dr. Jodie Katon is a core investigator and epidemiologist and health services researcher at the VA HSR&D Center for the Study of Healthcare Innovation, Implementation, and Policy at the VA Greater Los Angeles Healthcare System. Her research focuses on reproductive and sexual health and health equity. She and I co-lead the VA Reproductive Health Work Group, and she conducts research in partnership with the VA Office of Women's Health Services and the VA Office of Health Equity. We now want to introduce our wonderful panelists, and we're so grateful for them to be joining us today. Our panelists today include Dr. Ava Marie Conlin. She's the principal investigator of the Department of Defense Birth and Infant Health Research Program, based at the Deployment Health Research Department at the Naval Health Research Center in San Diego, California. Dr. Conlin earned her doctorate of osteopathy from the Philadelphia College of Osteopathic Medicine before completing a Navy obstetrics and gynecology internship, general medicine officer service with the United States Marine Corps, and a preventative medicine residency where she received an MPH in epidemiology. She's board certified in public health and general preventative medicine and is a proud Navy veteran, Marine spouse, and military mom. She has been with the Naval Health Research Center for nearly 20 years, publishing many peer-reviewed publications and collaborating with multiple DoD, federal, and state agencies, as well as universities and pharmaceutical companies in her research focused on health outcomes among military women, infants, children, as well as vaccine safety. We're also fortunate to be joined by Captain Monica Lutgendorf. She's Associate Professor and Chair, the Department of Gynecologic Surgery and Obstetrics at the Uniformed Services University of the Health Sciences. She earned her medical doctorate in 2004 from the Uniformed Services University of the Health Sciences. She completed an internship and residency in OBGYN at the Naval Medical Center in Portsmouth in 2008 and subspecialty fellowship in maternal fetal medicine at Madigan Army Medical Center in 2014. As noted, she's currently the Associate Professor and Chair of the Department of Gynecologic Surgery and Obstetrics at Uniformed Services University of the Health Sciences. Her research interests include neuroprotection in preterm infants, non-invasive prenatal screening, simulation, quality improvement, and domestic violence and post-traumatic stress disorder in pregnancy in the military. Finally, we're also joined by Celeste Romano. She received her MS in epidemiology from the University of California, Los Angeles. And with the DoD Birth and Infant Health Research Program, she provides evidence on the distribution and determinants of pregnancy and postpartum health outcomes, as well as infant health outcomes around military families. Her research spans health disparities, pharmacoepidemiology, and occupational epidemiology. As we said, we're really grateful that all of these valuable team members have come today to give us an overview of the DoD Birth and Infant Health Research Program. So thank you very much to all of them.
Thank you so much for the introduction, Elizabeth, and thank you all for joining us today for the presentation. We hope to give you a broad overview of the Birth and Infant Health Research Program, highlighting some of our specific studies that may be of interest to many of you, and then looking forward to a lively discussion with our discussants, as well as any of you who may have questions for us. Next slide, please. So as required, this is our disclaimer. We are military service members or employees of the government, and this work was supported by the U.S. Navy Bureau of Medicine and Surgery and Defense Health Agency Immunization Healthcare Division under our work unit here at Naval Health Research Center. The views that will be expressed in this presentation are those of the authors and not necessarily those of the Navy, Department of Defense, Uniformed Services University, or the U.S. government. And all work was approved by a Naval Health Research Center Institutional Review Board and is in compliance with all federal regulations. Next slide, please. So you've all come today to hear about our research program and just a little bit of background on why reproductive health research is important. And I'm guessing based on the audience, you know much of this. But our military population, our service members, face just many military unique exposures. And some of those are potential, have a potential known risk to reproductive health. And others may have, some of these exposures may just be potential risks. And some exposures we may not even think carry any reproductive risk, but we may find out many years later that they do. We have our service members in a number of deployments where they can have deployment-related exposures. They're also living at geographically diverse duty stations, both in the United States and abroad. And those duty stations are small cities at times that bring their own potential risks and exposures, some of which we know at the time and some of which come along many years after a service member and their family may have been stationed there. Our service members also receive a number of compulsory vaccinations, and some of those can be inadvertently received during pregnancy. And all of these reproductive factors can really impact readiness. So for our DoD audience, that translates into operational readiness and having enough of our force available and healthy enough to do the work they need to do. And for our VA colleagues, those reproductive factors and reproductive issues can extend beyond the military service years, often when somebody has delayed their childbearing and reproduction after their military service. The fact that we have more and more women serving in the military and that their roles are expanding in the military, I think has really done a lot to bring this topic to the forefront of everyone's minds. There are a number of civilian registries that work in this realm, but really cannot accurately assess a lot of the issues specific that our military families experience. And within our military health system and in healthcare in general, obstetric services are highly utilized. So there's very much value in assessing those highly utilized, high cost obstetric services within a military health system. Next slide. So the DoD Birth and Infant Health Research Program originally started as the DoD Birth and Infant Health Registry. You'll hear me refer to it as BIHR, B-I-H-R, throughout the presentation. And it was started back in 1998, really after that first Gulf War, when a lot of the issues that we just spoke about came to light and were on the forefront of people's minds when service members were coming back from combat, from deployment, and concerned about some of the exposures they may have experienced, and then their following reproductive health. It was the expertise and vision of Dr. Megan Ryan that really started BIHR back in 1998. And now I can say that we've been around for 25 years. It wasn't that long ago that it was the 20-year celebration. And now, a quarter of a century of work in this realm. It is a retrospective assessment, initially set up to look at birth defects. That was its primary mission. But over time, we've added other adverse infant health outcomes. Although we have the name research in our, the word research in our name, we really do a lot of surveillance for birth defects and other adverse health outcomes among our DoD beneficiary, including preterm birth and birth weight, growth problems in utero and in infancy, and always assessing the male-female sex ratio of the infants as an overall indicator of population health. We can also assess maternal health outcomes, increasingly able to look at pregnancy loss among DoD beneficiaries who experience exposures of concern. And those exposures of concern are things that we might read about in scientific literature that we think we can investigate in our program. Sometimes those are questions that are brought from leadership, from service members and veterans themselves, just a number of ways that we think of the different outcomes that we can assess. Next slide. Our methodology utilizes the Military Health System Data Repository, otherwise known as the MDR. I'm sure many of you are familiar with that, but it contains administrative medical claims data, ICD-9 and now ICD-10 diagnostic codes, as well as CPT codes. And those are covering inpatient and outpatient healthcare encounters, whether those are occurring at military or civilian healthcare facilities. Essentially, everyone who is eligible and enrolled in the TRICARE healthcare system, the MDR is capturing that data. We then also link to other information from the Defense Manpower Data Center, like the parental and military demographics, service member immunizations, and other service member military unique demographic information like branch of service, race and ethnicity, military occupational specialty, and things like that. We also conduct robust validation through our data abstraction efforts that's limited to care that is being provided throughout the military treatment facilities, but we're able to utilize the electronic health record ALTA and Essentris to do those validation efforts. And then we're able to link to a number of other data sources. Some of those that we've linked to date include the Millennium Cohort Study, as well as Navy physical fitness data, the DoD Serum Repository, Deepwater Horizon responder survey data from the Coast Guard, as well as the Joint DoD-VA Suicide Data Repository. Next slide. As I mentioned earlier, this is a retrospective assessment, and because we were initially established to do surveillance for birth defects, we do follow the National Birth Defects Prevention Network guidelines for the major birth defects that we routinely conduct surveillance on. And that information gets published, it was annually through 2003 and now every other year through the NBDPN. And they essentially include our DoD data as another state. So we show up in their publication just like all of the other 50 states in Puerto Rico and Washington, D.C. We do require that we see one inpatient or two outpatient diagnoses on different days in order to assign case status. And then our ongoing validation efforts, continuously looking at that and assessing individual birth defects to see if those are those case definitions accurately capture cases, or if we might be overcounting or undercounting, and assessing predictive value, positive and negative predictive values. We do routinely look through the whole first year of life among the live births, trying again to capture all of the birth defects. Most of those would be expected to be seen through that first year of life, but we do have select efforts where we've now extended the infant population into childhood through age 2 and all the way up to age 5 years of life. Age 2, mostly looking at vaccine coverage during that time, which may be of less interest to our VA colleagues. And then 5 years of life, embarking on a study looking at children with medical complexity up through age 5. So we do have the ability, we do limit that population to infants and children that we have visibility on throughout that period of time that have been eligible or enrolled in the TRICARE system. Next slide. So data from our 20 plus years from the Birth and Infant Health Research Program show that there are over 2.6 million infants born to DoD beneficiaries during this time. And it is about 100,000 per year, roughly, give or take. The median age of mothers is 27 years, and about 13% of these infants are born to active duty mothers. So it's kind of about a 85, 15, 100,000 births each year, roughly, to overall, and then about 13 to 15,000 of those to our active duty mothers. And among those active duty mothers, they tend to be the majority to our mid-enlisted rank personnel. And most overall in the birth population occur at civilian facilities. But this has really changed over time. Back when we started, most of the births, 58%, were at military treatment facilities, with a smaller number in the civilian sector. But most recently in 2021 data, we're showing only 30% occurring at the military treatment facilities and 70% in the civilian population. One drawback of that is the inability to do validation on all of those births that are occurring in the civilian sector. We do have births in all 50 states and more than 20 foreign countries. And pretty consistent with our civilian counterparts, we see an overall prevalence of birth defects of about 3%. And also consistently, we see atrial septal defect and ventricular septal defect most commonly, as well as hypospadias, clubfoot, and pulmonary valve atresia and stenosis. Next slide. Some graphical representations of what we were just discussing. On the left, you can see BIHR overall numbers, as well as those to military mothers and those to dependent spouses. It's clear here that the dependent spouse population really drives the overall numbers, making up the vast majority of them. And then also the births that are occurring specifically within the MTFs. You can see that trending downward over time, remaining pretty similar for the military mothers over time. And then in the map on the right, our average annual births by state, color representation of the states where we see the most live births within the United States: California, Texas, Virginia, North Carolina, and Florida. And although it's not represented here, of interest as well, although it's not, we don't have a large number of births in Alaska and Hawaii, the births that are occurring there make up a large proportion of the overall births that are occurring in those particular states. We have a heavy military presence and representation among their birth numbers. Next slide. Just a table showing the characteristics of this population. You can see that most of the births are to mothers less than age 35, and most are married, with some differences between the total population compared to the active duty population. You can also see some of those differences in the race and ethnicity differences, greater diversity within our active duty population compared to our overall, again, is driven by the dependent spouses. And Army has the most births just based on the size of their service, followed by, depending what population you're looking at, Navy and Air Force, and mostly to our enlisted rank personnel and families. Next slide. Subsetting our population to the active duty women, we have 330,000 infants born to this population of 236,000 women with a median age of 25 years. Now, their births are predominantly at the military treatment facilities, as we showed on that last graph, and 30% at the civilian facilities. Again, most of the births are to the mid-enlisted rank women. And for this population, we have a broader range of data on exposures and outcomes available. And we have more confidence in the data that we have. For our dependent population, we're limited just to the MDR data, and then we're limited to information about the sponsor from our demographic information. But for the military women who are their own sponsor, we know about their specific military occupational specialty and the vaccinations that they've received, and information about mortality. So oftentimes we will limit our studies to this active duty population. And then of this population from 2003 to 2014, we have a subset where we have looked at all pregnancies rather than just pregnancies that result in a live birth. So this was really the first attempt to be able to look at pregnancies that might result in a loss, which is very complex and problematic in a way using the MDR data. And that went through 2014 because of the transition to ICD-10. So I'm happy to report that our efforts are moving along well now to expand that population into the post-ICD-10 era through 2021, and hopefully be able to once again assess pregnancies, including losses. Next slide. So this is the type of information that we'll hope to have then through 2021. This is just limited to the ICD-9 era, 2003 to 2014. But you can see again the information on all pregnancies, with the majority resulting in live deliveries, but then a smaller number of losses and a particularly small number of stillbirths. But great interest in studying more about early miscarriages and losses, as well as stillbirths. But here you can see there's a large number of unknown outcomes. And some of that is due to women who may have a loss that may not seek medical care or seek medical care outside of the TRICARE system. There's also the potential for elective abortions that occur outside of the TRICARE system, although sometimes we do see visibility of post-care for those. So definitely excited about expanding this into 2021 and being able to say a little bit more about pregnancies and the impact of pregnancy and pregnancy loss, potential risk factors for stillbirth among this military women population. Next slide. Some strengths and limitations of our program. We are primarily limited to live births, but as I just touched upon, we do have this increasing capacity to assess, I guess, starting with defining pregnancies and then assessing the outcomes of those pregnancies. When we're looking at defects, we typically look within the first year of life, but as I mentioned, we are able to go through early childhood for select efforts. We all know that ICD codes are good at identifying diagnoses and procedures, but they really can't describe the constellation or severity of some of the defects. And we are limited to those who are using TRICARE coverage. We do continually validate our data, so we have confidence in the accuracy of the electronic diagnostic data that we're using, but that is limited to the MTF-based care. And as the amount of care decreases in that system relative to the civilian, then by default, we're unable to validate the majority of our cases. And then this ability to link to other data sources, some that I mentioned that we're already linking to, but really, any other data sources that are out there that might include environmental and occupational exposure data, particularly individual level occupational exposure data, and then self-reported data through other surveys and death data to assess mortality. Next slide. This just highlights our fact sheet for our BIHR program, kind of showing an overview and then getting into some of the publications, which is what we're going to transition to next in the presentation. But certainly I have this available if anyone is interested in seeing a comprehensive outline of all the work that we've done. Next slide. And with that, I will turn over this portion of the presentation to a long-term collaborator with the Birth and Infant Health Research Program, Captain Monica Lutgendorf.
Thank you, Ava. So this is just a discussion of one of our recent papers looking at the prevalence of PTSD among pregnant service women. We did find that during this study time period between 2007 and 2014, that about 1.7% of active duty individuals were affected by PTSD in their pregnancy. And we found that PTSD cases were more likely to be non-Hispanic white individuals who were unmarried and previously had deployed. We also found high rates of comorbid mental health conditions, including depression, adjustment disorders, and anxiety disorders. And so those rates ranged as high as 61% for comorbid depression and about 40% for adjustment and other anxiety disorders. And about 44% of the individuals that had PTSD identified in this study used psychotropic medications during the pregnancy. And that was compared to a 7.2% rate of psychotropic medication use in non-cases. Next slide, please. And then we did a follow-on evaluation to look at the association of PTSD in the current pregnancy with prenatal care utilization and infant outcomes. And so we found that cases with PTSD were more likely to initiate prenatal care during the first trimester by a slightly higher percentage, and then to utilize higher rates of prenatal care during the pregnancy. And PTSD during the pregnancy was not associated with an increase in infant preterm birth, small for gestational age, or major birth defects in this cohort. And finally, we postulated that the universal health care that individuals had available to them and their prenatal care utilization may have mitigated some of the adverse pregnancy outcomes that have been seen in other populations with PTSD during pregnancy. Next slide, please. And so just kind of looking at a snapshot again, I think there are some differences between the VA and the military in terms of pregnancy and PTSD outcomes. In terms of the studies that have been done in the VA, this is kind of a selection of that. And pregnancy-related anxiety was found to be a robust predictor of postpartum depression in pregnancy. And then it also seems that the literature highlights that PTSD diagnoses and other life stressors can be correlated with maternal alcohol misuse in the postpartum period. And then military sexual trauma seems to be a significant association with low birth weight infants, possibly also with preterm birth and an increased likelihood of postpartum depression and anxiety. So I think that there's definitely some correlations in the studies that are similar, but then potentially some other differences as well. Next slide. And then I think this is for Celeste.
Yes, I'll jump in. So I'll start by discussing our work on severe maternal morbidity among active duty service members, which was published in the American Journal of Perinatology in 2021. For this effort, we linked personnel and medical encounter data to identify a cohort of delivery hospitalizations among active duty women from January 2003 through August 2015. And we applied 21 and 20 condition algorithms for severe maternal morbidity that included and excluded blood transfusion. And these algorithms were developed by the CDC. We found that from 2003 to 2015, active duty women experienced an increase in severe maternal morbidity that followed national trends, despite protective factors such as stable employment and universal health care. And similar to other populations, military women of color were at higher risk for severe maternal morbidity relative to non-Hispanic white military women. Next slide, please. And just last year, we published a paper in the American Journal of Obstetrics and Gynecology on pregnancy-associated and pregnancy-related deaths among active duty members of the military. For this work, we linked pregnancy data to National Death Index Plus data from the Joint DoD-VA Suicide Data Repository. Deaths were categorized as pregnancy-associated if the death occurred during pregnancy or within 1 year after pregnancy, regardless of the cause. And then among those, deaths were categorized as pregnancy-related based on the cause of death codes, medical encounter data, and medical records indicating a cause related to or aggravated by pregnancy. Next slide. We found that from 2003 to 2014, pregnancy-related mortality from any cause increased from 13.1 to 16.1 deaths per 100,000 live births, though it appeared to peak in 2006 to 2008. When we looked by cause of death, we found that the percent of pregnancy-related deaths from direct obstetric causes declined, whereas deaths from suicide and unintentional overdose increased. Next slide. And here we show causes of pregnancy-associated mortality overall and by age and race and ethnicity. And you can see that for non-Hispanic Black individuals serving in the military, there was a higher proportion of deaths due to other pregnancy-related mortality, so excluding suicide and unintentional overdose, whereas a smaller proportion of deaths among non-Hispanic white individuals serving in the military were due to those obstetric causes, and more were due to suicide and unintentional overdose. So there's also, as we saw, more suicide and unintentional overdose deaths occurring over time. We also saw that more were occurring among non-Hispanic white service members. Next slide, please. All right, and I'll pass it back to Ava for this section.
Thank you, Monica and Celeste. Here we just wanted to highlight some of the deployment-specific projects we've done over the years. And most recently, Dr. Clinton Hall and our team published a study on health outcomes among offspring of U.S. Coast Guard responders to the Deepwater Horizon oil spill, which occurred in 2010 and 2011. For this, the male sponsor exposure window was 3 months before conception, whereas for females, it spanned 3 months before the date of their last menstrual period through the infant's date of birth. And the adverse health outcomes we assessed were generally comparable between the infants who were born to the male oil spill responders and non-responders. There was a suggestive risk for any poor live birth outcome among infants born to female spill responders, but that should be interpreted with caution due to the small numbers of female responders that we had in the study. Next slide. We've also, over the years, have looked at birth defects in infants born to personnel exposed to military deployments and combat. And Anya Bukowinski on our team a number of years ago looked at the birth defects among infants who were born later in 1998 to 2004 among men and women who served in the military during the first Gulf War from 1990 to 1991. So those infants were being born 7 to 14 years after the deployments, and they were not at higher risk for having birth defects. And the parental in-theater exposures we assessed were not associated with long-term higher prevalence of birth defects among this population of infants. And then we've also looked at birth outcomes among military personnel following exposure to documented open-air burn pits before and during pregnancy, and burn pit exposure at various times in relation to pregnancy and for differing durations was not consistently associated with an increase in birth defects or preterm birth in these infants. Granted, there's not good individual level data for that particular exposure, and it was more based on unit exposure data geographically. Next slide. We've also looked at outcomes among pregnant women who were in the Operation Tomodachi registry after the tsunami and potential radiation risk in 2011. We have examined health outcomes among infants born to women who have been deployed to U.S. military operations during their pregnancy, which doesn't happen too often, but often enough to assess. And then we've done a good bit of work in maternal and infant safety of vaccines received during pregnancy. Some of those are pretty military unique vaccines like anthrax and smallpox, yellow fever, and Japanese encephalitis, as well as typhoid vaccine. But others are actually recommended in pregnancy. And because we have a large compliant population, it serves as a good resource to look at safety of influenza vaccine during pregnancy, as well as Tdap vaccine during the recommended times during pregnancy, and now COVID-19 vaccine during pregnancy as well. Also, malaria prophylaxis is of interest to the military and the CDC and travelers in general. And we've looked at Malarone exposure during pregnancy and hope to investigate doxycycline exposure during pregnancy as well. Next slide. Some future directions and potential collaborations that really kind of follow on to some of the things I just mentioned would be looking at more long-term follow-up assessments of some of these previous deployment specific studies focused on women who then went on to seek VA care, who we have visibility of more years of care after their active duty military service, when potentially they weren't included in our studies because they weren't thinking of pregnancy and their families at that time. And then also looking at long-term outcomes following specific diagnoses. So some of the diagnoses that we see in our active duty women, like hypertension and gestational diabetes, are these the women that are then going on to have chronic hypertension or diabetes and seeking care for that potentially in the VA system. And then we haven't done much work on the birth outcomes among the retirees that are within our birth and infant health research program. We're usually limiting it to those that are currently serving, but we would have some births to retiree veterans who remain visible within the TRICARE system. And we're excited to think about the potential of intergenerational study of our Burr infants who have now given birth to a second generation of Burr infants. Next slide. And just thinking about that a little bit, just looking at our early data from 1998 to 2000, there are more than 3,000 second generation infants born to women who were included in Burr as infants in those early years. And about 400 of those are born to active duty women. About 1,100 are born to women who are now dependent spouses, and the remainder to dependent daughters that we really don't have visibility of their continued care. But we do expect these numbers to increase. Granted, one limitation is that these infants who go on to serve in the military and then have additional Burr infants are healthy enough, have that healthy worker effect that they're able to serve in the military for us to have the visibility of them. Next slide. So in conclusion, it's imperative that we find an appropriate balance between maintaining optimal operational readiness and minimizing adverse exposures among active duty women. It's difficult, but it's certainly necessary. And the BIHR program has the capability to look at a broad range of reproductive health outcomes among both service members and their families. We can link with relevant military exposure data. And ultimately, our goal is to provide findings that can help inform and direct policy development that can implement change, leading to increased health and wellness of our service members and their families. And I think future collaborative efforts have the potential to expand these assessments from just beyond the military years into the veteran years as well. Time and time again, we're contacted by veterans who might have concern about their reproductive health, and our research to date provides relatively reassuring information among our population who are currently serving in the military, but it always has been frustrating to not be able to say more to our veterans who have now decided that the time is right for them to consider their reproductive health and encountering issues and concerns that they think could potentially be related to their military service and exposures. So I think that's really critical moving forward. Next slide. It's important for me to recognize the outstanding people that I serve with on the DoD Birth and Infant Health Research Team, many of whom have been with the team for many, many years. They're listed here, as well as many DoD and civilian collaborators that we have been privileged to work with, who have come to us with research ideas and have really served as subject matter experts and fostered a lot of the collaborative research that we've done. We were core funded through fiscal year 22 by the Navy Bureau of Medicine and Surgery. Now that's just become specific funding for one project, but our other funding comes from the Defense Health Agency Immunization Healthcare Division, as well as some military health systems research dollars that come our way through collaborations with both Dartmouth College and Dartmouth Hitchcock Medical Center, looking at military health systems research, looking at capacity, regional variation, and trying to maximize that for the MHS. Next slide. This slide will just be our contact information if anyone has questions and wants to follow up with us afterwards, but I'll turn it back over to our discussants and see if they have questions or if others in the audience do. Thank you so much.
All right. Well, I think we can just jump into the Q&A. There's so much here in this presentation. And I know my synapses are firing just thinking about all the questions. I wanted to start actually with a question from the audience, and I encourage audience members to type into the Q&A any questions you have. I have some prepared questions, but we want to engage you as well. So the question is, could we ever replicate, and I'm paraphrasing, a study that has previously been done on Vietnam era veterans among Iraq, Afghanistan veterans? And this was based on one of the papers that came from that prior study, pregnancy outcomes among US women Vietnam veterans from Kang et al. I'm not sure if I'm pronouncing the author's name correctly. So if you're familiar with this study, the audience members, wondering about the possibility of replicating that as a collaborative effort, thinking logistically.
Yes, and I'm not familiar with the specific methodology. I'm seeing in the question, why or why not, but that is, I think it is important to assess that more recent population of our military service members with the longevity of that conflict. It would be difficult. They're all difficult, but varying levels of difficulty, I guess, in trying to accurately assess those deployments in and out of theater, and then trying to pinpoint what we think the exposures of concern are for those various locations. And then, again, people that are repeatedly deploying and have, they're at least healthy enough to do that, and how that might impact some of the outcomes. And I'm assuming this was male veterans, but we're thinking now female and male veterans would be of interest in this most recent conflict.
My apologies, I did not read the
Oh,
title.
women, yes,
Yeah,
women
so
veterans.
I forget if this particular study sampled both men and women, but my understanding is it's a cohort study that is based on repeated surveys. And there is a similar type study for Iraq, Afghanistan veterans. Again, I think the challenge may be that we are sampling veterans. So there's folks, especially in a 20+ year conflict, who are career service members, who we wouldn't capture in these. And as you point out, the time is a real issue. And we got an answer from, I think, it was solely a women cohort, actually. There's another question from the audience.
And just real quick on that too, Jodie, I think the fact, that survey information, I think that's great to potentially link the medical administrative data, right?
Yeah.
For all the years of visibility that we have, potentially then even some follow-on data from the VA side, but then pull in that survey data as well, to get at some of those more nuanced exposures that we might not be able to assess just from the military records.
Yeah, exactly. And I think triangulating that with the military record information can help also address things such as potential recall bias and other issues. So we have another audience question. They, really appreciate your work and are asking about, potential collaborations, just because of the, multitude of questions that can be asked. This person specifically is focused on musculoskeletal injuries in relation to pregnancy and postpartum, which I actually don't think we have great data or research yet on in the veteran population. So I'm excited that someone is doing this work. But that gets me to a question I posed in advance, which is really considering the challenges of collaborating across federal agencies, but also the importance of doing research in that way, thinking about, both what might be some shorter term goals for collaboration versus more of the, pie in the sky as you build trust and communication and understanding of, what data you all have, what we have, and how this can work together. So just kind of broadly asking about potential collaboration opportunities, again, both short-term and long-term.
Yeah, and my audio went out there for a few moments before, so I don't know if you addressed Emily's question here about this one in particular. That is of interest to us as well, and we have a PhD candidate that is actually interested in musculoskeletal postpartum physical therapy and that, so definitely interested in that realm. Reproductive health and musculoskeletal injuries, two huge factors for military women. So bringing those together and looking at them in combination, I think is great. As far as collaborations, I think, something like this, a specific question that utilizes both the what BIHR has to offer and what the VA healthcare system has to offer about these women, and then trying to look for funding for that specific study. And then I think being able to show relevance, show importance for that specific study, I think would go a long way then to trying to convince funders on both sides to have something more long-term, to kind of build continued collaborations. Mm-hmm. But anyone who's, willing to take that first step, that has this great idea and says, we have data, you have data, let's bring them together. I think that would be phenomenal.
Great. So maybe we can connect you with the audience member after the fact if they want to reach out to myself or Elizabeth. And also it looks like you've included your contact information as well in this slide. Yeah, it also sounds like, thinking about what would be the topics of, high interest kind of that might require, some further meetings, discussions around, really trying to understand where there would be shared interests, which I think there'd be plenty. It's just a matter of identifying. Are there any other audience questions at the moment? Otherwise, I'm going to continue with my own line. I don't see any. So one of the things, something that's been a lot in the headlines in recent years has been maternal mortality. And you all showed some of your data specifically striking around suicide, overdose, and homicide. And, there's also been some data out of Louisiana and some other researchers around this. I'm very curious as to whether or not, how your numbers compare to some of these national numbers. As you illustrated, there's reasons one might think the numbers in your population should be better, but also reasons why we might suspect they could be worse. And I think a lot of folks, even though it's not really a strictly like-to-like comparison, that's sort of their reference point. So I'm curious if you could speak to that.
Yeah, I can chime in here. So we did make some of these comparisons in the published study that I referenced. And we found that if we excluded suicide and unintentional overdose from our estimates of pregnancy-related mortality, then those mortality estimates were actually a lot lower than what's been reported on nationally. So again, just looking at like obstetric-related causes, women serving in the military appeared to have lower rates of mortality than nationally. But the rate when we included suicide and overdose, or just from suicide and overdose specifically, was higher than what we saw nationally. So there definitely appears, to be an opportunity to really step in more and focus on maternal mental health during pregnancy and also postpartum, because we saw a lot of those deaths were also occurring, well after pregnancy, beyond 42 days postpartum. So just continuing those kinds of mental health check-ins further on, post-pregnancy.
Yeah, and I think I would add to that too, that I think the pregnancy-associated deaths that are occurring in that first year after birth are really an important thing that's understudied and perhaps even undercaptured in our patient population. So I know that the CDC has been partnering with the Defense Health Agency to try to stand up maternal mortality review committees to specifically partner with the states, since in that year after birth, some of these maternal mortality events can be due to things like homicide, substance use overdose, and things like that. And so I don't think we're fully capturing that within the military treatment facility if they don't come back to us and get brought back into our system. So I think definitely an important opportunity and a significant cause of maternal mortality in the civilian and in the military setting.
Great. We have a question in the Q&A about specifically around stillbirths and severe birth defects and Camp Lejeune exposures, wondering if there is any effort to collect information around those exposures and birth outcomes through surveys or other means.
And that's not something that we are involved in at present. It does predate from when our research program was set up. So we do have, in those early years, the live births, and it's more the recent years where we have information on pregnancies. But this example does, I think, serve to illustrate another potential use of our research program, looking at specific exposures and being able to kind of marry those up and identify a population that we could then reach out to for survey information, to do kind of like we were talking about, marrying up our data with yours and some of the surveys that are available out there.
Great. Yeah, I had not heard of anything for this, so interesting to note that right now it's kind of an open question.
Yeah, and it does show. I mean, you never know when some of this information will be useful or needed, right?
Right.
We've learned a lot from the Vietnam era and, birth effect many years after that with Agent Orange. And I think, so many of the things now are based on those lessons learned, but we're certainly not there yet, right? We don't have everything that, back when this was happening at Lejeune, we didn't have something like this in place. And then you hope if there ever is anything in the future that, having this infrastructure and having it ready to go will serve everyone well.
Yeah, I mean, that's always the challenge, right? With any kind of surveillance efforts is trying to foresee what is the data you're actually going to want 20 years from now. So speaking of data, I know that it's, again, often at the top of mind for veterans and been in various headlines, as well as, brought up some discussion around VA policy. I'm curious, have you been able to use, or do you know of anyone who's trying to currently use your data set to examine specifically infertility and potential causes of infertility, related to military exposures? We get these questions a lot in VA, certainly, but I'm curious about kind of the ability of your data to do this.
Yeah, so the MDR data, although our population originally limited to those live birth pregnancies wouldn't necessarily capture infertility unless it preceded that birth. And now as we're looking at pregnancies, same thing, we might see the infertility diagnoses that are then followed by a successful pregnancy. But we have been asked this question more and more as well. We've done a little bit of work many years ago looking at smallpox vaccine. We were asked if that was potentially associated with infertility. So we did work there. And then we also worked with the Millennium Cohort Study team, who has had varied questions over the years about infertility. We actually called that one impaired fecundity just based on the way the questions were worded. So we've done limited work in that. But I think, especially not necessarily from our birth side and infant health side of things, but from our service women's health and readiness perspective, I think it's something we could get more involved in. Using the MDR data, again, limitations to that on who's seeking care, who's eligible for care, who has those infertility diagnoses. But we could look at that in advance of successful pregnancies, or perhaps define, a population of all of our active duty women, and then look at those with infertility diagnoses and try and look for potential associations with some of the associations with some of the other exposures we might see in other data sources.
Yeah, I appreciate that. This is a really difficult and perpetually thorny topic to research, especially when relying on, actually, there's no perfect data set, whether it's administrative or survey data. It's just an incredibly challenging area of reproductive health, but matters to so many folks. Elizabeth, do you see any further questions in the chat? I don't want to miss any, but I could also ask questions all day. So
we just had a question about getting citations to find the published studies from this presentation.
I believe the slides are being made available. I don't know if they're downloadable right now, but they will be. And I think all the citations were included on there.
And then that fact sheet that we featured in the one graphic too, I can provide that. I'm not sure who will disseminate the slides, but we can also provide a comprehensive fact sheet that references all of our publications over the years.
Fantastic. Maybe Maria, would that go to you?
Yes, I can update the handouts with the citations and any other documentations at the back of it. I have a quick question I would like to ask the team. I was just wondering if any of the studies are related to children with disabilities, like autism and anyone on the spectrum.
That's a question we've been asked before as well. So really when we were limited to that first year of life and then even to the second year of life, those diagnoses are coming a bit later. So it's only in recent years that we would have the potential to look at those diagnoses through early childhood. And I think as we've developed more relationships with our pediatric colleagues, I think that is one that we would like to investigate, as long as we have a subject matter expert that would be able to help with those case definitions, knowing the limitations of our data, knowing that it is medical administrative claims data. And so how reliable are those diagnoses? And how many of those would be within the MTF system such that we could do validation on some of those cases. But again, I do think that is of interest to the team, maybe less so to some on the VA side, not as just by nature of the care you're providing, not as concerned necessarily about some of those outcomes in children, but maybe so, knowing the impact that those outcomes also have on the parents as well. So I think it is, I don't want to make it an excuse that it's hard with the medical administrative data, but it is. And just really to have confidence in those case definitions of what we would call a diagnosis based on that. But yes, anyone out there that wants to potentially collaborate and look for a funding source on that one as well. Yeah, great ideas. And this is what happens each time we talk about it. We're always met with a lot of great questions and research ideas from those that we talk with. So looking forward to hopefully fostering some of those along to become projects and studies.
Yeah, I would just add, Ava, that we're currently kicking off a series of studies on children with medical complexity, which includes, a wide variety of disabilities in that definition. And to make the data even more complicated, because we're following children over time for an extended period of time, now through 5 years, because of the nature of TRICARE and this population, there's a lot of mobility in and out of the system. So also thinking about who do we have visibility over for an extended period of time becomes more complicated as we try to define these cohorts.
Yeah, and just to further point out, I think the kind of definition and getting to this case definition issue, diagnostics around autism, and like even we don't refer to the autism spectrum disorder anymore, I believe, as of the DSM, the last update, which further complicates, the case finding and really wanting to have really certainty in that data. I will say, I think from the caretaker perspective, that would be something of interest, something, I hear a lot when interviewing veterans for my study, because I focus on women veterans and they frequently have young children at home. Are issues around caretaking and balancing, their own medical needs and other needs versus taking care of their families. And certainly having a child with medical complexity adds to that. So I think there could be some interesting points of collaboration, but also points for my VA colleagues to kind of jump off of that in terms of providing support and care for the veteran population and enhancing their access to care.
Yeah, and that study that Celeste just mentioned too does include that component. Just as in addition, to looking at the children with medical complexity, then the mental and behavioral aspects of parental health among that population as well. Right.
Well, we have 1 minute remaining, and I do want to take advantage to just thank you all once again. I'm going to keep thinking about this presentation and kind of cogitating on different ideas, and I'm sure others will. And I'm looking forward to hearing more in the future and connecting. But do you have any last words you'd like to leave the audience with?
No, just to thank you and Elizabeth and Adriana and Maria and for all who were instrumental in getting this set up. And certainly thanking Captain Lutgendorf and Celeste for joining me in the presentation, and for all who took time out of their busy schedules to come and listen to what we had to say. We're really, really appreciative and look forward to talking with some of you in the future.
Fantastic. Well, again, you can see on the slide an email if you would like to reach out to Dr. Conlin and her team. And we appreciate all of the audience participation. With that, I think we will conclude this cyber seminar, but thank you, everyone.
Yes, thank you very much for taking the time to prepare and present for today, and for the audience. Thank you, everyone, for joining us for today's HSR&D Cyber Seminar. Sorry, I have allergies and my throat keeps closing up. When I close the meeting, you'll be prompted with a survey form. Please take a few moments to fill that out. We really do count and appreciate your feedback. Have a great day, everyone.